Welcome to On the Beat, the pulse of gynecologic oncology, brought to you by the Regroupement des gynécologues oncologues du Québec, RGOQ. Before we begin, a brief disclaimer. This podcast is supported by an unrestricted educational grant from AstraZeneca. The content, expert selection, and topics discussed are fully independent, and the opinions expressed are those of our experts, free from any influence by AstraZeneca. This discussion is intended solely for healthcare professionals and is for informational purposes only. It is not medical advice and should not be taken out of context. By listening, you agree that this content is not intended for patients or the general public. For personalized medical advice, please consult a qualified healthcare provider. Now, let's get started and explore the pulse of gynecologic oncology.
The next is, cervical cancer. I think we're pretty much comfortable with it. And, PD-L1, I mean, as a clinician, we offer, we add Pembro to the Keynote 826 regimen if they're PD-L1, but kind of in our head, we know that most cervical cancers are going to be PD-L1. So anything new, anything that our audience should be aware of in terms of PD-L1 testing?
Like you said, it is sort of pretty, I think, well established now, of course, and among pathologists as well. It is a difficult test to interpret. Not everyone, likes it, and there's, a certain incentive sometimes where it's difficult to get more people on board. And again, in PD-L1, I think to me the larger issue is the turnaround time, right? Mm-hmm. So you may have a recurrence and from a cases that was biopsied in an outside center, and now all of a sudden, you want to access this combination. So you have we have to request a test to come to your center, and then and then depending on the availability and turnaround time there, you may be looking at a few weeks, right? So it's always for me there's always a bit of frustration then when we're kind of looking at these cutting edge therapies, and along being cutting edge are extremely expensive therapies, but seems like we're really using them suboptimally in many contexts just because of this turnaround time. If we had, I think it's really important to emphasize how we have to really put more effort and more light onto the efficacy of predictive testing and predictive biomarker. Because exactly, we're going to spend a lot of money just to use a therapy, which its effect could be limited given the delays of the biomarkers or even the quality of the biomarkers testing that was done. So, PD-L1 is a great example where I think we have to streamline the process.
You said a word that sparks my excitement, which is like prediction and predictive models, which is obviously what a lot of my research focus in is. As you said, these need to serve as something. And, I think, again, to reiterate, HRD, what is HRD at the end of the day? It's not, like you said, it's not a molecular change. It's not an IHC. It's at the end of the day, a prediction to response to PARP inhibitors, right? That's the point. And so if we go back to cervix, I was just reading a paper today about circulating DNA, HPV ctDNA, and it was actually a trial that was going on when I was a fellow at Princess Margaret. And that really shows that, you can use the circulating tumor cells as a prediction of response to the therapy, or prediction of risk of recurrence in the future. And so, these are all nice. We're talking about implementing them, but ultimately we are hoping to give more of a percentage of response to these medication. Patients want to know survival in months and why should I take this new medication that has I have to put eye drops and so I think we're really going towards that, where we need to be more objective and give people percentages and numbers. So I think it's getting pretty exciting. And one of the last topics that we wanted to talk about, we could probably start a whole new podcast on this, because I think people will have a lot of questions, especially people who do colposcopy, but obviously vulva, what is going on? It's a new language. I feel I have to go back to learn everything again, Vavin and devil, and I didn't even learn this in fellowship. So, and I feel sometimes we're still stuck to the Divin and the Uvin, because we know what that is.
Right.
but HPV dependent, HPV independent, and then the subgroups of all that. I think we're a bit, still struggling. And maybe in a few minutes, just give us like, what are the updates?
Of course. Yeah, I know. I mean, I do, as part of a representative maybe to this podcast of the pathology community, part of me feels a little bit bad as far as the nomenclature that's changed. But, it's changed so much, but I think for a good reason. And obviously there's a lot of data that came along with this. But, just like you said, there's a few subtypes of vulvar lesion, but I think the best, and maybe to give a little bit of context to this, right, is that we have the HPV associated, that we're quite, familiar with from the cervix. And then, more recently, what's been very much clarified is that a large proportion of vulvar squamous lesion are HPV independent. And it's really this subgroup where a lot more data has emerged. The HPV. So we have on one end the HPV associated, on the other end the HPV independent, which, by the way, in the cervix is also emerging and still much lower proportion, but it's still also a subtype. Now, this subgroup of HPV independent is divided in two. It's essentially one group that is HPV independent and P53 or TP53 mutated. And then third group would be HPV independent and TP53 wild type. In the recent past, like you're saying, it's not even so long, where the TP53 mutated subgroup were often referred to as DVIN and still are in many instances. And then it's this third group of HPV and independent and P53 wild type, aka not mutated. That's where the different name emerged, like the DVOL or the VAD lesions, and these names really refer to certain morphologic characteristics. And given that there's so much overlap in even DVIN and those VAVIN or like DVOL or VAD, I think there's really a push now to sort of leverage more the molecular classification as a diagnostic tool. So now we really would separate them in those three as I named them. HPV associated on one end, then HPV independent, and the HPV independent become either P53 or TP53 abnormal, and HPV independent TP53 normal. And that's really based on that approach now that we focus. Sometimes and as far as just correlating with the morphology, often what we mean by DVIN nowadays, it should be the P53 and abnormal, TP53 mutated. And if you see reports that refer to the lesion as a VAM or DVOL or a VAD, typically that should be P53 normal. That said, it was not necessarily the case not so long ago. So make sure to always be, in communication. Obviously, they were starting to realize that these molecular subtype have different clinical kind of characteristics.
Well, for sure. Right? And we've started to notice that in recent months because, traditionally in our understanding, DVIN means go for surgery, whereas like UVIN or other VIN, like we can just, kind of treat them with either local medical treatment. So, it really does make an important role. And recently I've seen, because of this discrepancy, there's some DVINs we weren't sure. And ultimately the next biopsy was an invasive carcinoma. So it really is very important for us to know. And so I would imagine that the HPV independent P53 wild type would be a bit of a better prognostic group, correct?
Yeah. So those P53 wild type, when we follow them, we find that they typically, if they become invasive, they usually become verrucous carcinoma, which are more indolent type, whereas the TP53 mutated one are usually will have a much more aggressive and infiltrative course. So yes, there is a distinction. That said, we also see sometimes those transforming, those HPV P53 wild type eventually transforming into a TP53 mutated tumor, and as such also typically have a more aggressive course. What's important though, and I think what sometimes happens is again, and it's all about the communication, but sometimes those HPV-independent and TP53 wild-type tumor can be sampled superficially and then are sent to pathology, and then our interpretation will be essentially normal. Especially on the surface, these lesions can look completely normal. And then, what has happened is sometimes it's like then it's rebiopsied and another biopsy and it's still normal. And at some point the clinician, contacts the pathologist and is like, this is like a 5 centimeter lesion now. Like what's going on? So, for us, it'd be very important to know, like, what do you see? Is there a nodule or something that will help us greatly sort of interpret it?
That's interesting, yeah. And, I think, what we've been talking about throughout this podcast is like the limitations and access and the turnaround time and the processing. And, right now I really feel like Joe Rogan. And so I need to ask you, like, where do you see the role of AI coming in and trying to accelerate it? And I think, pathology is one of the fields where I think AI is gaining like the most interest with the cervical cytology. So I imagine there must be some up and coming things for the molecular testings, right?
Yeah, no, I think there's so much promise as far as the molecular testing. We're hoping that it could even, and we're talking about turnaround time earlier, maybe, it can give us a preliminary result as far as the molecular profile. It's not surprising. It's been shown already that some, testing on a certain, just scanning a certain tumor and then using a machine learning based algorithm can predict, let's say, certain mutation status, as such that you can imagine a future where we would get, a tissue sent for, scan, like this slide would be scanned as part of routine patient workup, and then we would run an algorithm that would give us like an MMR status, a poly status, and then maybe an HRD status in the case of tubo-ovarian lesions. And then already be, it could be like, okay, there's a level of confidence of, 95% that this is HRD. So then the patient can already, be either maybe in some case enrolled in clinical trial or obviously just put on certain, booked for certain therapies or meeting medical oncologists, and then waiting for maybe molecular confirmation from the sequencing that may take like 2 weeks, but really sort of optimize this logistics. I think it would be amazing for sure.
I think this has been really, really informative and really a great podcast, Basile. We're really lucky to have you, and we hope everybody on the RGOQ really benefited.
Thanks so much again for having me. It was great.
Thank you for joining us on the Beat, the Pulse of Gynecologic Oncology. We hope today's episode offered valuable insights. For more content and to stay informed, visit us at rgoq.ca. Until next time, stay informed, stay connected, and continue advancing the care of women with gynecologic cancers.